and symptoms of his advanced cirrhosis and his current admission. So can you tell me why, despite having advanced cirrhosis, he has low to normal LFTs?
Yeah, look at the bottom of that one.
Yeah, I was like, go find that one slide where he talks about it.
He has no good hepatocytes left.
Okay, good. Right, so this comes up a lot is you hear of patients that have advanced liver failure, advanced liver disease. First things you want to do is check LFTs and they look normal, right? And so it's good to remember that they have no good hepatocytes left if they are far enough along. Group 2, tell me about why this patient's got a high INR.
Decrease synthesis of clotting factors.
Okay, so definitely decreased synthesis of clotting factors with poor hepatic function with regard to synthesis. And also, depending, if he's still, it says that he's been abstinent for 9 months, but you know what Dr. House says, everyone lies. So it could also be malnutrition because he chooses the whiskey over actual food that has vitamin K in it. Group 3, how about pruritus?
High bilirubin levels can lead to itching.
Okay, good. How about group 9? How about hyponatremia?
Probably due to his fluid overload.
Fluid overload. Every time I have a patient that comes to my medical ICU with liver disease, they are hyponatremic. Somebody wants to put them on normal saline to improve their serum sodium levels. And in fact, you should do the exact opposite, is you should fluid restrict and diurese because it's a fluid overload problem. How about group 12? Talk about this low blood pressure. And it's not just in this, while the patient is inpatient, but at home at all times. They normally run more hypotensive.
Because there's an increase in nitric oxide and less circulating blood volume.
Okay, and what is the significance of nitric oxide? Why does that matter?
It's a vasodilator, so it dilates the blood pressure, or it dilates the blood vessels.
Yep, good. How about group 24, hyperbilirubinemia?
Yeah, his liver isn't doing what it's
So it
supposed
can't
to.
get conjugated, so it just goes on.
Just chilling.
The liver can't conjugate and excrete the bilirubin, so it builds up.
Yep, good. So you can't get rid of it, you can't clear it, and not only does it sit there and make it yellow, but it also will make it itch. How about group 14? Why is the patient confused?
Increased ammonia.
Okay, so they got elevated
They have
ammonia
nice
levels.
commercials.
Anything else you can think of?
They have nice commercials on like top of mountains and stuff, looking out. That's what we were typing in our notes.
So in addition, other byproducts that our liver normally conjugates and clears are structurally similar to benzodiazepines. Right, so when these patients have liver disease, they will conjugate various different endogenous products into benzo-structured byproducts to excrete, but then they can't excrete those. So you have buildup of almost benzodiazepines. Group 22, why does this patient experience bleeding?
Combination of the clotting factors and varices.
Okay, varices, and then what contributes to those varices is portal hypertension. So that backup in pressure also is what makes the varices worse and then end up bursting. How about group 11? How about ascites?
Could it be due to an electrolyte shift in fluid retention?
I will take your electrolyte shift and I'll say hypoalbuminemia. So your liver doesn't synthesize enough albumin, and then the albumin that it does synthesize is poor quality. And so you lose oncotic pressure, which causes your vessels, not only are they vasodilated, but it causes them to be more leaky. And it turns out that your blood volume tends to float into the peritoneal space. How about group 7, low platelets?
Chronic thrombocytopenia.
Yep, so thrombocytopenia is the definition of low platelets, and it's because their liver has poor synthesis, right? So your liver has a terrible time actually producing them. How about group 17, hypoglycemia?
Oh, he can't produce glucose because his liver.
Yeah.
You got it, Kendall.
His liver isn't producing any glucose. Did you hear me?
Right, so one of your major functions of your liver is storage of glucose. You got glycogen stores there, and if your liver isn't functioning, it also can't store your glycogen and break it down into glucose as necessary. Good. So liver failure, liver disease, is one of the most extensive and complicated organ failures because, as you can see, it affects every other organ system. We'll talk about neurologic, hematologic, renal, etc. So we'll talk about all those things, but it's important to know the rationale, the physiologic reason that all of these other organs fail, because it logically will tell you how to treat those underlying or those secondary issues. So this is a great example of a Monday morning. You come in, and this patient presented maybe on a Saturday or a Sunday. They've already got an active med list, and it's up to you to figure out what we can do better. So there's a list of interventions that can be made. So this is a great idea for what type of things you guys would do on rounds, at least in my ICU. So group 16, tell me some intervention that you made. Give me a couple of them.
Dr. Hawkins, can I ask you a question real quick from Athens on the last slide?
Yes, ma'am.
You asked why is the INR high, but the INR is 2.3. Would you consider that to be high?
Yeah, it's very normal.
So as an international, so that's a great question. So as a normalized ratio, all of us in here, unless we are on warfarin, we should have an INR somewhere between 0.9 and maybe 1.1, right? So everybody with an INR of 1 should have 100% the ability to clot or bleed compared to everyone else. So this patient is, their INR is elevated. You say therapeutic because it's between 2 and 3, but that's only when patients are therapeutically anticoagulated with a vitamin K antagonist. So this patient's INR should be 1.0-ish at baseline since he's not on any anticoagulants. Does that answer your question?
Yes, thank you.
Okay. Group 16. So what are some interventions y'all made on this patient?
One intervention would be to change the
Sorry, we can't hear. You're breaking up.
I'm so sorry. We would change the lactulose to 30 mils, not grams, to be given every 1 to 2 hours until these stools. And then
Okay. So you would increase the lactulose. What else you got?
we'd also recommend to change the spironolactone to furosemide ratio to a 100 to 40 ratio. So perhaps making spironolactone 200.
Okay, so you would increase the lactulose to target stools, and you would increase the spironolactone to optimize the ratio between the spironolactone and the Lasix.
Yes, and
Okay.
perhaps in addition we would maybe titrate the propranolol for a heart rate goal of 50 to 60.
Okay, good. How about group 26? What do y'all have in addition? You can either disagree with something they said, or you can add something to the list.
Like 45 mils.
We said we would do albumin replacement for the fluid loss, so we would do 5 grams per liter loss, so it'd be 40 grams of albumin.
I don't know that they have removed any fluid yet. All they have done is they looked at his belly with an ultrasound and they saw 8 liters of fluid present. So they haven't actually removed anything yet. So I agree that's a great recommendation to make once they have removed the fluid via paracentesis. So group 26, what else you got?
Okay, for hypoglycemia, we would see if they're tolerating a diet, and if not, we would treat it with B10W instead of B5.
Okay. You would optimize, give them less fluid with the same amount of sugar with B10, or you can see if they can tolerate a diet and give them some sugar. Good idea. What else you got?
Let's see.
Group 5 want to help them out. What other recommendations do you have for this patient?
We said since they had a variceal bleed that we would want to give ceftriaxone for 7 days.
Okay. What else?
And since they did have a high ammonia level and a little bit of confusion going on, we weren't sure how they were being fed or if they were being fed, but we wanted to make sure their protein intake wasn't any greater than 1 to 1.5 grams per kilogram per day.
Okay, good. Do you have any other recommendations to make?
If the lactulose wasn't being tolerated or wasn't effective, you could add rifaximin to it.
Okay. How about group 19? What do you guys have? Anything in addition, or want to disagree with anything that's already been said?
Lasix or an lactone ratio thing.
They already did that.
Oh.
don't have any suggestions.
Okay. How about group 10?
I don't know what he wants.
Does any other group have any other recommendations to make that have not been made so far?
Group 10 said to discontinue the midazolam because it's a benzodiazepine-like product.
Okay, good. Anything else to add to that group 10? In addition to DC and the midazolam?
You should say that.
But it's not a benzodiazepine-like product. It is a benzodiazepine.
I have a question, Ms. Bam.
Okay.
Would this patient need fresh frozen plasma due to the high INR?
Okay. Do you want to do something to correct the high INR potentially? So here's all the things that I would recommend to this patient. Right, so somebody comes in with hemoptysis, they're bleeding from their mouth. Now, granted, most 9 times out of 10, somebody with advanced cirrhosis, they're coughing up blood. It's probably going to be a variceal hemorrhage. So for a variceal hemorrhage, you're going to do the octreotide and the Rocephin. But if it's an upper GI bleed that's not related to variceal hemorrhage, then you would put them on a Protonix infusion. So most of the time, if you don't know specifically the etiology of the bleed, you're going to treat all potential etiologies, and then once you diagnose which one, then you can stop the other treatments. So this patient, now that we know it's a variceal bleed, he got his band ligation, we can DC his Protonix infusion. The other group said to add ceftriaxone, and I agree to do it for 5 to 7 days for a variceal bleed. You can put a stop date on octreotide. Octreotide is very expensive, it's only indicated for 3 to 5 days. As the other group said, increase lactulose to titrate to 2 to 3 loose stools a day. DC the midazolam. We know that the benzo-like substances contribute to the altermentation and encephalopathy. Increasing spironolactone, a group said to optimize the ratio. One group said to give FFP for the elevated INR, and you could certainly give FFP. They probably would have given FFP when the patient presented to the emergency room bleeding, because that would have corrected his coagulation factors immediately. But FFP only has a half-life of about 2 hours. So the FFP would have dropped his INR to about 1.5 very readily. But after about 4 or 5 hours, it would have went right back up to where it was. So in the acute setting, FFP would have been effective. You could give vitamin K probably. His INR may very well be 2.3 simply because his liver cannot produce clotting factors. So vitamin K is really just to rule out if there's any degree of malnutrition. I agree with increasing the propranolol to a goal heart rate of 50 to 60, keeping in mind that he is maybe borderline. His blood pressure is a little bit on the softer side. So just making sure that you're titrating with your goal heart rate in mind, but also keeping an eye on his blood pressure. We said that these patients have pruritus due to elevated bilirubin, and you see that somebody ordered Benadryl for his itching, and Benadryl is not going to be effective. Cholestyramine, however, will bind bilirubin and decrease itching. So a nice pearl there, you can use cholestyramine for hyperbilirubinemia associated pruritus. I definitely agree. I think this is a great catch for you guys. Not directly pharmacy related as the diet. So if he can tolerate his diet, then that'll help with his glucose, and also to be mindful of his sodium and his protein intake. And then we talked about his glucose as well.
When you say another way, what other way would you do it besides diet?
Like the other group suggested, potentially put them on a D10 infusion if they couldn't tolerate any nutrition. Good. Any questions about that?
I have a question.
Yes, ma'am.
You said empirically you treat for a GI bleed or variceal bleed if they came in like coughing up blood, and then you see the other when you figure out the cause. Is that what you said?
Yes, ma'am.
Thanks.
What was it that you said about the vitamin K?
So vitamin K, so we said that the patient has an elevated INR for one of 2 reasons, right? Either poor synthesis of clotting factors because their liver is broken, or, and it could be a combination of, or a degree of malnutrition. So if I give the patient vitamin K, it will eliminate the argument that it's malnourishment. So if I give them vitamin K and their INR goes down, maybe to 2.0, 1.9, then I know that they had some degree of baseline malnutrition, and their liver has some functionality of producing some clotting factors. Sometimes you give vitamin K and their INR will stay the same or even continue to increase because their liver function is just that crappy.
Got it, thank you.
Okay, anything else before we go to the next? Okay, so the next day, they do a large volume paracentesis. They removed 7.5 liters, and lactulose was up titrated. And he has stooled 4 times since the change, yet he's still encephalopathic. So I'll give you guys a minute or two to talk amongst yourselves, figure out what you want to do now.
So I'll be given albumin now. And rifaximin. We'll just add rifaximin to it and give an albumin. 5 grams per liter oil.
Sorry, to be clear, the team took all of your recommendations that we just talked about on the previous slide. So this is just updated, relevant information for tomorrow.
Okay, so give them 35 grams.
Yeah. Over 7.4 times 5. 35-ish. It's like a cheap one. Aaron said that, and I agree. Oh my god.
Okay, so group 23, what y'all want to do?
Add rifaximin, and give 7.4 grams of albumin.
Wait.
Alright, how much? 5 grams of albumin.
Wait.
Per liter, so 37 grams. My bad.
Okay, so we're milking it. Yep, so they did the large volume paracentesis. They were able to get off almost 7.5 liters. And so because they removed greater than 5 liters, you're going to give 5 grams per liter. So I just rounded up. So different places that you read, there's different literature to support different amounts. 5 grams per liter, other places will say 6 to 8 grams per liter. I just remember 5 because if I have to remember that if I only give albumin if they removed at least 5 liters. So if they remove at least 5, then I give 5 grams per, and then I'll just round up. So for this guy, definitely 37, 38 grams, just round up to 40, no big deal. And then I would add rifaximin because, like you said, lactulose, even though he was stooling appropriately, was still not completely treating his encephalopathy. Any questions about that?
Where'd you get the dose from?
Dose of what? Normal dose. So you guys don't have to know the rifaximin the question here is where does rifaximin dose come from? So rifaximin only comes as a single dose. It's 220 milligrams twice a day period. So don't worry about knowing the dose. It's an understood thing. There is no changing of it. So 3 days later, you see he's on lactulose 4 times a day. He's stooling 4 times. He's on rifaximin 220 milligrams twice a day. Still encephalopathic. His repeat ammonia level is 95. So, any thoughts on what we can do for this guy now? This is up for anybody, just to see if anybody has any thoughts. So the first thing I want to talk about for just a brief moment is the role of repeat ammonia levels. And I think I put a little bit of context of this in your pre-class material, but every patient that comes into my ICU, especially if they have liver disease, it is just creatures of habit. They order daily ammonia levels to trim. The only time you should ever get an ammonia level is when the patient first presents to the emergency room. Okay? If the ammonia level is greater than 200, the chances of them surviving their hospital stay are minimal. Okay? That's the only thing really that an ammonia level can tell you. People like to trend ammonia levels and look and try to trend that with encephalopathy. I can have an ammonia level of 120 and have this same conversation and give this lecture, whereas Emily could have an ammonia level of 65 and be completely encephalopathic and unfunded. Okay? So ammonia levels are very patient specific. So I can't tell you anything about treating based on a serum ammonia level. So I get an ammonia level when they first walk in the door. Over 200, I got a good idea of prognosis. Otherwise, no other clinical utility. The only caveat to that would be a patient like this. Right? So a patient is on lactulose. They're stooling 2 to 3 loose stools a day. And they are also on rifaximin. Right? So what I have in my toolbox to treat hepatic encephalopathy, I have given them all of them. And then I check an ammonia level, and their ammonia level has not gone down. Right? I think it was like 95, 97 when they first got here. They're still encephalopathic. I checked a repeat ammonia level because their brain is not improving, and it hasn't moved. So this may be a patient, even though I'm treating their hepatic encephalopathy correctly, they may be deficient in their body's natural ability to clear ammonia. So another option for refractory hepatic encephalopathy, this is the answer to your second question, is zinc sulfate. Right? Zinc sulfate is something you can give 2 to 3 times a day, specifically in patients that are already on maximum doses of lactulose and rifaximin and stooling appropriately, but still have encephalopathy and hyperammonemia. That is a very important point. Okay. Questions before we go to this patient? All right, I'll give you guys 5-6 minutes to see which orders you as the pharmacist would verify or reject given this clinical situation.
Let's not give her the Norco. So it's probably 24 to 48 hours because she has right upper quadrant pain. Or stomach pain or whatever. And that's when that happens. She's not jaundiced or extensive coagulopathies, right?
Hemoglobin is good. Platelets look good. Yeah.
She doesn't have hypoglycemia, so she's probably 24 to 48 hours.
What is her? It's 33 micrograms per milliliter. Oh, bless you. Thank you. Thank you.
So can you use an acetylcysteine for if it's over 24?
It says it's above the 150 line, and she's not, right? The APAP level's 33.
Yeah, she's in that gray area.
That's good.
So for these limitations, is this saying it has to be over 24 hours, or you can't use it if it's over 24 hours?
I think you can't use it if it's over, because it like cuts off.
Okay. Oh yeah, that's right. So we can't use it anyways.
And then it says the only one of these things that she matches is that her APAP level is like greater than 20. Her ALT isn't over 1,000. And we don't know if she's taking.
Are these ors or ands?
Don't know. Good question.
Ors.
Then yeah. And if it's ands, then no. If she Norco, if she takes it every 6 hours, then
She doesn't need any Norco because it has
I'm trying to figure out like how much Tylenol she takes in a day.
Oh. No, this is for the hospital.
Is this like It says orders pending verification. Never mind. Is this 4 grams a day of chronic ingestion? It has to be, right? This like history of chronic ingestion greater than 4 grams. That has to be per day, right?
Yeah. If you've ever taken more than 4 grams of Tylenol.
Tylenol doesn't help me. I'm gonna have you perfect.
She doesn't need the Nadolol because that's for like encephalopathy. She doesn't have that. She doesn't need the charcoal because it's not within an hour. I mean, I guess we can give it to acetylcysteine.
I guess so.
Group 19, what orders would you verify?
Just if we would approve the N-acetylcysteine. You got it. Depending on the Rumac mapping nomogram, we would approve the N-acetylcysteine. We know that the acetaminophen level is 33, but we don't know how long ago she took the Tylenol. We would reject both of the activated charcoal because it's likely that she took it over an hour ago. And then we would reject the Norco because it has Tylenol in it. And then we had no idea about the Tylenol.
So based on the phases of toxicity for Tylenol, what phase do you think this patient is in?
Phase 3? Or phase 2 right now?
Right, phase 2. So just knowing that she is now symptomatic, you know that she took the Tylenol overdose at least 24 hours ago, right? You don't know anything about the history or time of ingestion specifically, but because you know that the first 24 hours or phase 1 is asymptomatic and this patient is now presenting with symptoms, then you can infer that she's already outside the treatment window, so to speak, for the Rumac-Mackie. However, it does have caveats, right, in terms of when you can still use it. So I'll tell you that we would give this patient N-acetylcysteine. So if you were going to verify the order, would you choose to give it IV or PO?
IV preferred due to no smell and duration of treatment. IV because there's no smell in the duration of treatment.
Yep, so she's already nauseous. You can treat her in 24 hours as opposed to 3 days. So IV is typically going to be preferred. You have some 16, 20, 25-year-old person that took a handful of Tylenol, not near enough to kill themselves, but just enough to give themselves attention that you would normally not treat. You may give them PO Tylenol or PO N-acetylcysteine, not because it's effective, but just to teach them a lesson, right? So that is also something that we do. So I won't make you guys calculate this out, but it's very important that you know the dose, how to dose N-acetylcysteine, right? Numerous studies have shown that yes, people know when to give and not to give N-acetylcysteine, but no one, it is a very common intervention for pharmacists to make because people order it inappropriately, okay? So it's important that you guys know the dose specifically of N-acetylcysteine. And then you said you would reject the order for the activated charcoal, and you would reject the order for Norco. Is that correct, Group 19?
Yes.
Okay, and tell me again why you would reject the activated charcoal?
Because it was taken more than an hour ago, so it wouldn't be effective.
Okay, and then what about the Norco?
It has Tylenol in it.
Okay, good. Any other group have anything to say about the Nadolol?
Isn't it for varices and she doesn't have that?
Yeah. No indication for it?
Okay, no indication, right? Nadolol is for portal hypertension, for varices. It is not for an acute issue. You all have a question or you want, right? Okay. All right, any questions or comments here?
Aubrey, I got it.
So the Rumac-Mackie, again, is within the first 24 hours, but there are limitations. So if you are unsure if you should give it or not based on various different limitations, if their Tylenol level is greater than 20, I don't care when they took the Tylenol, I'm still going to give it because the patient's symptomatic. Okay? There's other specific caveats as well, but at the end of the day, if you're unsure, the clinical benefit far exceeds the risk, so you're going to give it anyway. So day 2, patient's intubated for airway protection because her mentation is worsening, goes into a coma. You see her vitals that I have listed here. So what is happening and what do you want to do? So I'll give you guys about 5 or 6 minutes to talk amongst your group for this.
Read it real quick and tell him why he's wrong. Which one are you seeing the logo? Top.
Top, yeah.
Oh, She needs hypertonic saline. What's your ICP supposed to be? I guess since you put it on there, it's
I think
high.
it's low.
Hmm?
I think it needs to be low. Or,
Yeah.
like, I think
And her sodium's low, so it's like dose her up.
normal ICP is 5 to 15.
Okay, it's a bit high. Blood pressure is low.
Damn, her lactate is 6 pounds.
So she's in septic shock, right? Not septic, whatever, she's in some type of shock.
She's probably septic.
She's not profusing.
We don't know if she's in shock yet until we can give her fluids and vasopressors. The stipulation.
Yeah. Well, we should probably give her fluids.
Yeah, she's septic.
Because she's not perfusing, that's why I like to.
Acting Kendall's like she's dying. Or mean.
That's usually my go-to.
How often do you get for 17 minutes? They don't have that over 16 hours. Could we put her on liver dialysis?
I think we should.
Or an ELAD? I think this is a case where you wouldn't give someone LR considering her lactate is already there.
And her liver's failing. Can't change that to bicarb.
I wish I had an ABG.
No. Where's white blood cells? Is white blood cell 13?
I think that's normal.
What's it supposed to be? 14? 11? $4,500 to $11,000. So they're high. It's high. Maybe she has an infection because her temperature's a little high.
I hate that they don't put temperature in Fahrenheit.
Yeah. I think 37 is normal. What's the criteria for septic shock?
So like
Your lactate has to be above 2.
and then like
Your MAP is below
65.
something.
But like what pushes you over into shock is if your vitals or like if you're still meeting that criteria and
After
you've
adequate.
received like adequate fluid and vasopressin.
Okay.
Vasopressors.
I thought, is that the new guidelines or the old ones that were changed? Okay.
Before it was based off the CERS criteria.
Search, okay. So we need to give her some fluids. Nothing with potassium, so normal saline would be fine. Well, she needs the
But normal
hypertonic saline.
Yeah. But normal saline's acidic. Would you want to give someone? Would you want to give her something acidic if she's acidotic?
Well, we won't want to give her anything with potassium because she has 5.2.
And there's potassium in floss. Isn't there?
I mean, she definitely needs
Alright, so Emily, what do you think's happening with this patient?
something for ICP.
He's in phase 3 of APAP toxicity.
And what do you think we are concerned with in terms of phase 3 that the patient looks like they're experiencing?
Lactic acidosis.
Okay? And then what about their ICP being elevated?
Intracranial hypertension.
Yep, so we see that they have intracranial hypertension, they are at risk, or they are developing cerebral edema, and they are at high risk of brain herniation. So group 25, what do you want to do?
We said either give mannitol or 23.4% hypertonic saline.
Okay, what else?
We could do vital or artificial liver support.
Okay, what else?
Oh, jeez.
That's all I had. Maybe transplant.
Okay, yeah, that's a good idea too, potentially. Group 13, anything else you want to add?
Do you treat like all the symptoms?
That was all we had.
10 grams IV Tylenol.
Okay. So a few things. So I've listed all of them under ICP management. So you would actually do triple H therapy. So you would make sure they are hyperventilated, and then the discussion was hypertonic saline or mannitol, and then you would do hypothermia or at least prevent fever or hyperthermia. So all three of those combined are ways to decrease intracranial pressure. I also heard some folks here on the Albany campus calculate the patient's mean arterial pressure and saw that the patient's MAP, what did you say, Marcus, was 65? So they were borderline hypotensive. So fluids or pressors, you'd have to figure out if they were volume responsive. Odds are you're probably going to want to give pressors instead of fluid because fluid would worsen the cerebral edema, just more fluid on the brain.
Hypothermia is no longer recommended.
I have hypertonic saline in yellow. Again, because this patient, if you give a large volume of fluid, it's probably going to worsen their cerebral edema. And mannitol is a large dose, it's 1 gram per kilogram, and it's a lot of volume. So both of them are going to give you what you need. Most institutions in practice will probably prefer 23.4% hypertonic saline over mannitol, just because of the volume associated with its administration. So I said fluids or pressors. I preached the other week about making sure they're in terms of fluid responsiveness or pressors. So what ends up happening is, so this patient died, right? And they ended up herniating. So to have a good understanding of what brain herniation is, their brain, there was so much pressure or cerebral edema in her skull that it actually forced her brain down into her spinal column. Right, so that is what brain herniation is. You may have heard the term before, but it's good to understand what that is. At the bedside, what that looks like is a patient that, so sepsis, you talk about hypotension and tachycardia, whereas Cushing's triad or brain herniation is the opposite of that. They become hypertensive and bradycardia. And they become hypertensive because their body is trying to perfuse the brain in an attempt to not herniate. So when you're choosing in a patient, in general, fluids and pressors, and they have elevated intracranial pressure, and this also, the pathology relates, the physiology is very similar to hepatorenal syndrome. Right, so if you look at this guy struggling in the gym, I think y'all seen this before. Right, so let's say this arrow with these 5 pluses is the patient's mean arterial pressure. Right, so they have a pressure that's generated from their heart to perfuse some organ. In this case, it's their brain or maybe their kidney. Their brain has an elevated pressure that is fighting against that, right? So it's counteracting the pressure that your heart's giving with the elevated intracranial pressure or maybe intra-abdominal pressure with hepatorenal syndrome. And so you have two forces fighting against each other. And so you have a net perfusion pressure of whatever the difference between those is. So if we put that in context, this patient's mean arterial pressure minus their ICP, so 65 minus 39 is what, like 18 or 20, would give them a net cerebral perfusion pressure of only about 20. Right? Our goal organ perfusion pressure, whatever organ it is about 60. Right? So we are going to be reducing their ICP by all means necessary with Triple H therapy, etc. But we also want to make sure we're perfusing the brain. So if their ICP is 39, and our goal cerebral perfusion pressure is 60, then we should target a MAP of about 100 in this patient, right? So that'll give us our net perfusion pressure. And again, this goes the same thing with hepatorenal syndrome. So when you have somebody with any type of compartment syndrome, whether it's in their head or their belly or even their feet, you can reduce the pressure in that compartment that's swollen, or you can increase their mean arterial pressure, or a combination of the two. So, not something that you guys will be tested on, but it's physiologically a physiologic principle that's important to remember. So, 3 months from now, what? Right, we got a 25-year-old male brought in by EMS down in front of Waffle House after celebrating his last P3 final. So I'll give you guys about 4 or 5 minutes to talk about this patient. No.
What's the measure score supposed to be? What is the score that you
I don't know, he didn't tell us. It's probably in the reading that I was given.
Oh.
Cute little. I don't even know what
Over 32, you want to do steroids, so yeah.
What about pentoxafolin? When you give that?
Yeah.
Not before, like not the day of his death. Like day after.
What is the Lil score?
That's the prognosis. Or no, that's like to see if steroids are helping or not. The first one is just like to see if you need to initiate them.
So group 15, what do you want to do?
Start prednisolone.
Sir, because his score is greater than 32, our group decided to give him some prednisone.
Okay.
Prednisone, my bad.
Okay, prednisolone. Yeah, so if it's over 32, it says that you should start steroids. Okay, good. Now, prednisolone, prednisone, prednisolone is what was studied. If you wanted to send him home with prednisone tablets, that would be perfectly fine as well. This guy's an inpatient. Prednisolone obviously is a liquid. You may even do methylpred IV if you had to, but Either way, you get the point. Steroids if it's over 32. So 7 days later, you calculate a Lilly score to be 0.39. So group 8, how does this help you?
What is it supposed to be?
It determines whether you can discontinue steroids.
Okay, so based on this guy's Lilly score of 0.39, would you discontinue a steroid?
We're looking it up.
Oh, so if it's above 0.45, they're non-responders. So he's under that, so he's responding.
We think they're responding, so we can taper off.
Okay, how'd you make that decision?
Sorry, we meant continue for 28 days.
Why would you?
Okay, so Lilly score of what tells you that they are responding?
Less than 0.45.
Okay, less than 0.45 says that their hepatitis is improving with your steroid therapy, and so you said you want to continue for 28 days, right? It is not a pharmacist's job. These little calculators, these scores, are a little bit more comprehensive. So when we have a patient come in with acute alcoholic hepatitis, we will consult GI, and GI will put in their consult note, we have calculated the discriminant, the score of blank. And then they may or may not remember to do the Lilly. Actually, what they'll end up doing is they'll calculate both scores on day 1, and you'll have to know that the Lilly score is irrelevant at that point, and you'll have to remember to ask them to recalculate it on day 7. So less important to know how to score a patient, but more so how to interpret what those scores mean with regard to their drug therapy. So something else that has come up is pentoxifylline. So this is the STOPA trial that was published a few years ago, and it was, you see, 2 by 2. And what they showed was that pentoxifylline did not improve outcomes in patients, but in prednisolone, it improved their short-term mortality, but not their intermediate or long-term mortality. So sometimes in practice, I'll still see prescribers try to give steroids and pentoxifylline. And I try to curb the use, being that it is not shown to be beneficial. So again, just more recent evidence, not something that I would test you guys on because this is a more recent change. 23 years later, so this is your classmate several years down the road. Now he's 48, and you see that he has a history of alcohol abuse with cirrhosis. So I'll give you guys about 6 or 7 minutes to figure out what orders you want to verify, modify, change, or stop.
Oh man, we have that.
He should not be on this cardio.
maybe like Nadal or Prenol or. No, but
85 out of 48.
yeah, because the Pharisees, right? And so we try to do for a non-selective beta blocker. We don't need lactator ringers because, you know, liver.
Yes. This article he told us to read says that whatever guidelines, whatever recommended discontinuation of beta blockers if the systolic blood pressure is less than 90, and the serum sodium concentration is less than 120, or an AKI has developed.
Well, I'd say there's an AKI.
So I'm saying no to
No
the
more.
Gardasil.
Law. It says albumin 1 gram per kg for HRS, but like, isn't it just for liters removed? Where did it say that?
Well, the liters per removed thing was like, I don't know if that that was under like the ascites slide, so I don't know if that like falls under hepatorenal syndrome as well.
Well, he has ascites. I guess. And it doesn't have anything under hepatorenal syndrome in this PowerPoint. And he needs, yeah, he's got citronellin. So he's not on, what's it called? He's not on lactulose in the hospital, should he be?
Yes.
Lactulose and rifamycin?
I think so.
Should he? PMNs is 385, so he has an infection.
They gave him one dose, maybe they'll redose him.
Okay, so group 4. Which order would you verify as is? I kind of give it away as to how many things are in each section, but.
1. That my guess.
I don't know if that's right.
The ceftriaxone, right?
Yeah, since
Because he's,
bleed.
and he has an infection.
We would, can you? Okay. Spironolactone, the furosemide, and the Rosefin, we would continue that as is.
Okay. Agree or disagree with there?
Wrong.
We need to verify the lactated ringers bolus.
Excuse me, whoever said that.
And how about group 18? Anything to agree or disagree with that's been said so far?
There's only one thing that's correct.
Is it the verify as well as the Rosefin? And then you added LR to that?
There's only one thing that's correct as is.
Isn't it the ceftriaxone?
Is it too high because he has like liver problems and it's treated it?
We need to do a home dose of spironolactone and Rosefin instead.
heart rate or like blood pressure is always 90, right?
Systolic blood pressure.
Who was that? I don't know, not us.
It wasn't definitely.
Say, well, we're 18.
So I'll tell you that I would not verify anything as is. There are a couple things, and then we'll go through the orders that we would modify and then orders that we would change. So group 6, tell me, I'll tell you that I put Rocephin in the orders that I would modify. So group 6, can you tell me what I would change about the Rocephin dose?
The dose.
So now I'm telling you my answer. I want you to give me the rationale for it.
We would just do it daily, not twice a day.
Okay, good. How about group 20? Give me your thoughts on the vitamin K. Where would you put this? Where would you put vitamin K? I'll tell you that I put it in the modifications. So what would you change about it?
Yeah, I think he needs it, but I don't know how to give it. Is it right here? Hold on, Kate. Hold on.
We're thinking.
Hold on. I'm thinking. Hold on. What's today's being slow? We're thinking.
Whenever possible, vitamin K.
2.5 to 10 milligrams as a single dose.
How much?
2.5 to 10 milligrams as a single
So
dose.
not over 3 days.
So I'll tell you guys.
We would only give one dose.
Oh, go ahead. I'm sorry.
We would only give one dose.
Okay, you would change the duration to just one dose. So for the rest of you, I'll tell you that I put vitamin K, I put Rocephin, and I put albumin in the verify with modifications. I would change the fluids, and I would discontinue the Core and the diuretics. So I want to see what you guys can come up with in terms of why that is. So you're going to change the vitamin K. We talked about changing the Rocephin. So how about group 24? Can you tell me what I would do to change the albumin?
Single dose gin? With gin. You gotta get it with gin.
We would give it on day 1 and day 3 instead of just the one dose that it's written for.
Okay. So group 16, as of right now, we have that we would modify the vitamin K. We would give vitamin K 10 milligrams sub-Q times 1. We would give Rocephin 2 grams daily instead of Q12 for 7 days. And we would give albumin 1 gram per kilo on day 1 and day 3. So are you okay with those 3 orders?
Yes.
Okay. How about group 11? Anything you want to change about those 3 orders?
Obviously something's wrong.
Is this part, but like, do you think it's, I don't know, on Lexi? What do you say?
What's it say?
I'm trying to find like a proper indication, but I don't see one.
So the group that said you wanted to give albumin on day 1 and day 3, why did you want to give it on day 1 and day 3? What's the indication for that?
It's SPP, but it's off-label use.
What'd you say?
It's for SBP, like treatment of SBP, but it's like an off-label use
For
albumin on day 1 and then day 3. And also it's 1.5 grams per kg on day
For
1.
spontaneous bacterial peritonitis.
Okay. So a few things that we've talked about in the past and then something else to address now. So vitamin K should never be given subcutaneously.
What?
Right? Vitamin K comes in 4 ways. You can give vitamin K IV, PO, sub-Q, and IM. Okay? When you give vitamin K subcutaneously, it has very erratic absorption. You have no idea how much of that 10 milligrams of vitamin K you're actually giving the patient. So
How are you
erratic,
supposed to know that?
uncontrolled, not predictable absorption when you give it sub-Q. Sub-Q vitamin K should never be given.
I eat all of mine.
I didn't even put intramuscular on here, but something else that you'll see is vitamin K to be given IM. And if you think about it, you give vitamin K to a patient that has coagulopathy with an elevated INR, and when you give an intramuscular injection, you have to give them a big fat needle and stab them in the arm, right, or in the butt cheek. The last thing I want to do for a person with a tube with an INR of 2, 3, 4, or 5 is stab them with a big needle in a muscle, right? They're going to bleed more than usual. So for the indication that you would give vitamin K, I would also never give it intramuscularly. So vitamin K should only be given IV or PO. I don't know if this patient can take PO or not, so I put either one on there. One group said to give it just ×1. You wouldn't be wrong if you did it just as a one-time dose. I know that where I trained in residency, we did a lot with pre-liver transplant, and it was always a 3-day cocktail to make sure that they got all of it, to make sure that there was no underlying malnourishment. I agree with the group that said to change Rocephin from Q12 to daily. I think some time ago we mentioned ceftriaxone should only be given Q12 if a patient has meningitis. Right? You should never give Rocephin Q12 unless they have meningitis. Albumin, so the group said they wanted to give it on day 1 and day 3, which I 100% agree with, and that's specifically for the indication of spontaneous bacterial peritonitis. Right, so if we were treating this patient for hepatorenal syndrome, then we might have been okay. But because with this patient, we don't know if they have hepatorenal syndrome, we know that they have SBP. And so I would change the dose of albumin to 1.5 grams per kilo on day 1 and 1 gram per kilo on day 3. Albumin is something that physicians or prescribers always mess up. Okay? So we've talked about 3 different albumin doses for cirrhotic or liver disease patients. You have a specific albumin dose to give for patients with large volume paracentesis. You have a specific albumin dose to be given for patients with SBP. And you have a specific albumin dose to be given to patients with hepatorenal syndrome. So it is very important for you guys to know the different 3 doses for the different 3 indications.
You didn't give us doses, so.
Yeah, he has the,
His PMA
over 250.
Everybody good with that, what we've talked about so far, before I ask what words you want to change? Okay, group 12, I'm telling you that I want to change the order for the IV fluids. So what would you want to change it to, knowing that's now the right answer? What would you change it to and why?
Yep.
Lactate rigorous is contraindicated in stage liver disease. Change to plasma-like.
We have no idea.
Okay. Does anybody have any idea what we would change the fluids to? Or what we would change about the fluid order?
You could change it to plasmolite since they have end-stage liver disease.
Okay. So you want to avoid lactated ringers in patients with end-stage liver disease because you're giving them a large fluid bolus of 30 per kilo, and you may see that they can't clear the lactate or convert it to bicarb appropriately. So you would contribute to a lactic acidosis. Right, and the lactate's already 2.6. Any reason you chose plasmolite and not normal saline?
Hyperchloremic.
I think the chloride level is 111, so you'd want to avoid it.
Okay, yep. So definitely agree with that. They were already hyperchloremic, so we have specific ways to target only one specific fluid to give. Okay, how about group 5? What would you want to discontinue in this patient?
The carbidolol.
I guess what's left over is Coreg and diuretics. So why would it be pertinent for the pharmacist to not verify the numbers, call the physician and say, not so much?
I'm gonna read that thing word for word. Where'd it go?
So we weren't totally sure, but we were thinking maybe it's because the kidneys weren't being perfused adequately already.
Okay, and what gives you the inclination that the kidneys are not being perfused?
It's serum creatinine.
We were thinking because he had a really elevated serum creatinine.
Okay, so he's got elevated creatinine. That can either be for low perfusion. It can be because he's volume depleted. But specifically, I would say to hold the carbidolol because the patient's already hypotensive. Right? And similarly, diuretics, obviously we're going to, if they're going to make him pee and further decrease his blood volume. But we're also trying to fluid bolus him for his new diagnosis of sepsis. So we can't be bolusing him with fluids and diuresing him. So I would hold the diuretics and the Coreg because of his vitals, his continuous blood pressure, and hemodynamics. So why are we not treating this patient for hepatorenal syndrome? Right? Originally, somebody said to give albumin 1 gram per kilo for hepatorenal. And we said that we would change it and give him a larger dose, but for a different indication. And it's important to know, so this comes straight from your reading. So hepatorenal syndrome is a diagnosis of exclusion. Right? So you have to rule out all the other causes of AKI that would be relevant to this patient before you can say, I think they have hepatorenal syndrome. Right? So you see straight from the list, we got infection and hypovolemia and shock. We got all 3 of those things. Potentially, he potentially has SVP, etc. One thing I want to highlight for this patient, sorry for going backwards, the paracentesis results. Right? We think the patient has sepsis, so we're going to put him on antibiotics. They specifically chose Rocephin. You guys are thinking sepsis. You're going to do broad spectrum antibiotics, maybe with vancomycin probably. But this patient, we already have a pretty good idea that it's SVP. Specifically because you see the PMNs. So when they drew fluid off of his belly, it had 385 white cells, right? So when you draw fluid from someone's belly, if their white count, if the PMNs are greater than 250, that tells you that SVP is the diagnosis. Now we sent for culture. That culture probably won't come back for 2 or 3 days once something actually starts growing in the micro lab. But we can actually make some clinical decisions just based on the PMNs. Okay, day 6. Patient's hemodynamically stable, adequately volume resuscitated, they're clinically improving. They did a repeat abdominal ultrasound showing 4 liters. They decided not to tap his belly, but to just restart his diuretics. So they put in orders for Lasix 40 IV daily and spironolactone 200 daily. So I'll give you guys a minute or 2 to talk amongst yourselves in terms of what you would do with these orders.
Should do 280 instead of 240. Yeah, it could be up to 400, 160.
I mean, like, can if 200 to 40 okay?
No, I think it needs to be that specific ratio.
That's what I meant.
Yeah. Pretty sure. Don't know why I didn't read, but. Yeah. Can we go down? I don't know. I like his voice. I like the way he sounds, but it's just not interesting. He has nice skin.
Increase.
Lasix to speak.
Increase the dose and let us go home.
I want to like see what that looks like. Like, you just like stick a tube in their belly and it drains all the.
A paracentesis?
Is that just like sticking a tube in there?
I think I really just think they just like pull it out. Like you do.
I wish pharmacists could do stuff like that.
When I went
I want to intubate someone.
You know that residency visit that we had to do? I was on the liver transplant floor at Emory, and this dude came in like super duper, very severe sightings. Like his stomach was like triple the size of his body, and all they put in, and it was like super rigid. And the hepatologist was like, put in an NG tube, and we'll see if it like helps with the rigidity. So the nurse like shoved an NG tube down his nose, and within seconds his belly was all fishy again. And I was like, how does? I was like, what?
How did that work?
I don't know. I was like, what? And then I also saw a patient get intubated, and I saw that get
I want to intubate someone. That is a goal.
Yes. I'm sure you need a medical license.
No, I'm going to go to respiratory therapy school. Just so I can intubate someone, and then I'll go back to pharmacy.
But isn't that wild? All she did was put in an NG tube, and then his belly was
If you adjust the ratio of the diuretics, we said maybe to increase the Lasix to 80 milligrams.
Okay. How about group 25? You agree or disagree?
We're trying to figure out why one's IV and one's PO.
Because spironolactone
Okay.
doesn't come IV.
So maybe you want to switch the Lasix to PO. Is that maybe what I'm hearing?
Yes, but
Okay.
we don't
So
know
if
how
you,
close.
yeah, so if you switch the Lasix to PO, what dose would you give?
80 milligrams.
80 milligrams. Why did you double the dose?
Because you want the ratio to be 100 to 40.
Okay, so you would give them PO 80 milligrams. So is 80 milligrams PO, is that the equivalent dose of 40 IV, or are you actually changing the dose that was originally ordered?
Awkward.
I think the ratio is 1 to 2, so I think it's the same.
Okay, so the ratio is actually the same, right? So you could easily give 40 milligrams of Lasix IV. I think it's also a great idea to IV to PO conversion, so you could give it PO. But as the first group mentioned, they wanted to change the Lasix dose to optimize the ratio between the two. But it's important to remember that the bioavailability of Lasix is only 50%. So that 40 IV is actually the equivalent of 80 PO, and your ratio is the same, or is what you want it to be. Right? So this, again, this is another piece that is messed up in practice all the time, where people are not attentive to the ratios to be given appropriately, and they also don't account for bioavailability. You could recommend to increase the dose of both of his diuretics back to his home regimen, if you look back at what his home doses were. However, this patient is just getting over his sepsis or septic shock. I don't know if we put him on pressors or not. So he's a little bit tenuous, right? He's probably still in the ICU. We're probably trying to send him to the floor, maybe send him home. So I would probably be a little bit more conservative and start him on maybe this dose, and then maybe tomorrow we could go back up to his to his home dose if he tolerates this dose okay today. So don't get up and run, but if you see questions, slide, because there's going to be a quiz after this. But I first want to open the floor for a couple minutes to see if any campuses have any questions.
I didn't get the last.
Can you go back to the previous slide real quick?
So Savannah, do you guys have any questions about any of the material we covered today? No, we're good. How about Augusta?
So what's the dose for albumin in hepatorenal syndrome?
A gram per kilo times 1. So they dosed it appropriately in the case, but not for the right indication. So if they were going to get it for hepatorenal, it would have been all right.
The SBP is the 1.5.
So SBP is 1.5 on day 1 and then 1 per kilo on day 3. So I gave you guys a bunch of readings. I think I attached a lot of articles. So I would go through and screen the different adverse effects or systemic effects that we talked about today, and take note on like the albumin doses, etc. Any other questions from Augusta?
Yeah, I skimmed it. I didn't actually read it, and it did not help. So.
Okay, yes, Athens. When we gave a 23 years later cirrhosis patient the ceftriaxone 2 grams, was that treated like for the sepsis specifically? Because I kept finding 1 gram a day for 7 days for the SBP.
Yep, so 1 gram, I don't remember how large the patient was. I'm normally more aggressive in the ICU on doses. I'm trying to see where he is. I didn't give you his weight. So you would not be wrong to change the Rocephin to 1 gram. I'll tell you that I normally give 2 grams, just because I know their volume of distribution is much higher, especially when we're about to give him 30 cc's per kilo, etc. But that's more personal practice. And some other literature in pneumonia would tell you that if they're over 85 kilos to do 2 grams. But you're 100% correct in saying that 1 gram a day, once a day for 5 to 7 days is appropriate.
Thank you.
Other questions?
Is the 100 to 40 ratio for oral?
That is correct.
And then so you just cut the Lasix in half of that for IV?
Yep, so if you wanted to do oral spironolactone and IV Lasix, whatever normal ratio dose of Lasix you would give, you would just cut it in half since you're giving it IV. Any other questions from Athens?
Yes, sir. So, like, say our previous patient, if it was like 40 milligrams Lasix PO and 200 milligrams spironolactone PO, like, would you increase the Lasix or decrease the spironolactone? Like, which one do you base the ratio off of?
The ratio is going to be the same regardless. So you have the option to either go down on the spironolactone or up on the Lasix. So either one of those is correct for the test, right, or for the patient. But in order to decide which one of those decisions you have to make, I would look at the patient, right? So is he borderline hypotensive? And if we increase the dose, are we going to drain him too fast? Or does he have a big belly and his ascites is worsening from day to day? Because that would tell me to go up on the dose as opposed to down. So I would use either entity of the diuretics to make my decision. I would use the patient's clinical status to determine how I move those ratios. So
Okay, thank you.
These are all good questions. Any other questions from Athens? So some key things to remember, right? I normally don't fuss or harp on doses for you guys to know, but specifically in liver failure, there's a lot of doses that a lot of people mess up in practice. And that's all of your albumin doses and your N-acetylcysteine dose. And if you go on rounds in the ICU somewhere or on the floor or outpatient, and you recommend zinc for refractory encephalopathy, you will also be a rock star. Any questions at all, Bennett? Okay. No questions? Your quiz password, and somebody acknowledge in here that you can see your quiz? Okay. Yep, so quiz is active, so your password, John, is